Hi, everyone. My name is Isaac George. I'm the surgical director of the Structural Heart and Valve Center here at New York Presbyterian Hospital, Columbia University Medical Center. I'd like to talk to you today about decision-making in aortic valve disease and the lifetime management of aortic disease. This is a crucial topic faced by anybody with aortic stenosis in the current era, and we have new therapies and technologies that can help make these decisions. I'd like to review some of our processes and decision-making and how we come to a conclusion about how to treat someone and what our strategies are over the lifetime. I hope you find this useful. So what am I thinking when I see a low-risk patient? I try to go in unbiased, not as a cardiac surgeon, not as an interventional cardiologist, and I think, what is the best therapy for each individual patient? When I'm thinking a transcatheter valve or TAVR, TAVR, I think I have to be able to do a transfemoral approach, meaning taking the catheter up from the groin. If I'm thinking SAVR, which is surgery, I must be able to get the patient out of the hospital and get them home into rehab without any major complications. Each procedure's valve should have good performance, and they must allow for an appropriate cumulative risk of procedures over a lifetime. But what else matters to patients? These are the things that patients ask me. Will I survive the procedure? How long will I live? Will I get a stroke? Valve performance, does the valve work well? How long will this valve last? Is there any actual clinical meaningful difference between surgery and TAVR that's clinically important? And these are the things that our healthcare system are asking. How expensive is this procedure over the long run? And how long is a patient going to be in the hospital? We make some assumptions when we talk about patient preference and strategies for valve choice. If SAVR and TAVR can be performed safely with equivalent short-term results, why not allow patients to decide? And this is a very reasonable concept. Both are medically safe therapies. We should allow patients to decide. But we have to make sure that patients are informed, educated, and will weigh the risk of surgery versus later intervention. Oftentimes, patients will say, look, I just don't want surgery, but they don't necessarily know what the implication of that may mean. And that's really our job, to make sure that you're informed and educated about what the pros and cons of each procedure are, both in the short term and the long term. So size matters. It matters critically when we make these decisions, because it matters what the right choice will be for either TAVR or for SAVR as the first intervention. We currently do valve inside of a valve very commonly, and that's changed our approach to initial surgery. This is called valve-in-valve, or VIV TAVR. And that's where we take a surgical valve and we place a TAVR inside of it. As you can see here, it fits very nicely. It fits perfectly, and these results show that this can be performed. It's intuitively very attractive. It makes sense because it's less invasive than redoing open heart surgery. There's no incisions, no sternotomy. You're walking and you usually go home the next day. There's no time on a ventilator typically, no stopping of the heart and no bypass. It's technically doable in most patients, and it likely has an acceptable durability. It may not be very long, but it's usually acceptable, and you can avoid a major operation. So it's fast becoming the first option for high-risk patients after they've had surgery. Now, again, when we think about what you have as a space is actually limited because you have a surgical valve and then you're placing another TAVR valve inside of that. And there's only so many times you can do that. And typically it's probably only once for most patients. When we look at the number of patients who are getting aortic valve procedures over a range of ages, you see that the majority of patients fall between an age of 65 to 70. So that's a very important time range. And so when we think about how long valves last, surgical valves we think last 12 to 15 years, TAVR may last 8 to 10 years. We're going to have a lot of patients who are going to need repeat interventions or repeat procedures. And so that TAVR valve-in-valve concept becomes very important. But really, how long does any separate procedure really need to be? How durable does any procedure really need to be? When we look at life tables for patients or individuals in the United States born at certain years, a 70-year-old male is expected to live 14.6 years, and a female is expected to live 16.8 years. And when we talk about someone who are in their 60s, a 65-year-old male should live 18 years and a 65-year-old female should live over 20 years. So we really have to think about therapies that are going to get someone to their mid-80s. And that's really the goal of our strategy here in our valve center when we take care of patients. So we ask these questions: is SAVR more durable than TAVR? Is this really the correct question to ask? Should we really care if SAVR has a longer durability than TAVR? And I don't think that's really the key. I think what we need to do is to minimize the number of major surgeries over a patient's lifetime. And that's really the key concept that I'm trying to tell you here. So let's take an example of a 55-year-old male who has severe aortic stenosis, a trileaflet valve, and a 23 annulus. If we do surgery first, and then we do a valve and valve. So at age 55, they get surgery, and then they do a TAVR valve and valve, and that lasts 8 years. You know, the original surgery lasts 15, and then we do the TAVR valve and valve, that lasts 8. At 78 years old, we're likely going to have to do a reoperation. And then at 92, we can do, you know, an additional valve and valve. That's 2 sternotomies. Now, let's say we start with TAVR first. We do TAVR. That lasts 10 years, and then we do a sternotomy, and then we take out the TAVR and do an AVR, an aortic valve replacement. And that lasts 15 years, we get to 80, and then we do a TAVR valve and valve, and that lasts to 88. That's a very reasonable procedural sequence because we're only doing one major operation. The other procedures, again, are less invasive than a major surgery. Whereas on the top sequence, when we start with surgery, we're doing 2 operations, and that's potentially something we can avoid by using TAVR valve and valve. So when we look at what the future may hold for patients, it may be that we do TAVR and then TAVR valve and valve, then do surgery in their 70s, and then do a TAVR valve and valve again. That's one operation. But let's switch here. Now let's talk about a 70-year-old man who has severe aortic stenosis, a trileaflet valve, and a 23 annulus again. Let's say we start with surgery. We do a sternotomy and we fix the valve. That lasts 15 years. And then at 85, we do a TAVR valve and valve. And then we can do that until we're much older and we're in good shape. But let's say we start with TAVR at age 70, and that lasts 8 to 10 years. At 78 to 80, if we do a separate valve and valve, which may not work very well, you know, in their 80s, we're going to have to do surgery, and that's a sternotomy or some kind of minimally invasive operation, but it still requires a bypass machine, and it's still major surgery. And so here, I think this sequence on the top is much more preferable. Doing the operation when you're 70 is much better than doing the operation when you're 83. It's a faster recovery, it's lower risk. Patients are just going to do better. So you can see that this sequence is ideal for patients if you do the surgery first. So there's a sweet spot for TAVR. And if you're not in the sweet spot, surgery may be a better option for you. Now, the elephant in the room here is that we have complex operations that we have to do to remove these TAVR valves. And that may be a limiting rate of how we do these procedures, because this may be a higher risk procedure just to take out a TAVR. And that's something that we're going to learn over our lifetime soon, and we're learning now. How difficult will it be to remove a TAVR valve? It probably won't be easy. We have early data sets that show that the chance of survival is 90% or a little bit less than that, whereas it should be much higher than that. And that chance of mortality or not surviving is, again, much higher than if you just do a regular operation. And so this data will help guide these decisions, but it's probably not going to be so easy to remove that TAVR valve. So we do want to avoid situations where we're doing a complex operation if we can avoid it. And valve may not be possible in many patients. You know, some of these reports that are coming out show that up to 20% of patients may not have good anatomy for doing a valve and valve. So we have to be very careful of these decisions and this kind of data in the future. So in what situations do I personally and our valve center prefer TAVR? Patients who are very sick, who have a porcelain aorta with so much calcium that you can't do surgery, an obese patient with a high surgical risk. Older obese females in general do better with TAVR. Females in general better do TAVR. Patients with severe lung disease, I think if you're trying to put this in a bucket into ages, which is probably not the best way to think about this, but it's the easiest way to think about it. If you're age 70 or older and you have a good valve-in-valve option, then I think TAVR is a reasonable procedure for you. If you don't have a good valve-in-valve option, I think TAVR should only be performed in general at age 75 or greater or so. You really have to get a plan to get patients to the mid 80s, again, with one major operation, if that's possible. Now, when do I prefer surgery? These are patients with a high activity level and a larger annulus, a long life expectancy, patients less than the age of 70, fit patients above the age of 75 even, severe calcium that will prevent a TAVR valve from working well, obese patients who want to get a mechanical valve, bicuspid valves, a lot of them will require surgery just because of challenging anatomy. And again, we want to plan to do one major surgery or one kind of major opening of the chest over a lifetime. So how do we make decisions regarding valve therapy? We have to know the exact anatomic information for each patient undergoing TAVR or surgery. Each patient with aortic valve disease needs a dedicated TAVR protocol CTA. We have to understand and plan for every intervention for the rest of their life. And we have to sequence to do one sternotomy or one major operation at the youngest, fittest period of life. Current therapy has huge implications for future therapy, and that's very important for every individual patient. Surgery is a good place to start with most people less than the age of 70. The preferable TAVR sequence is likely a sapien valve than an Evolut valve. And we have to plan for coronary reaccess. If patients have blockages, we have to be able to access the arteries to do stents. And sometimes we can't do that with certain valves, certain TAVR valves. Or we're going to be doing more bypass operations in older patients after TAVR. We have extravagant procedures that we can do on patients, but we should leave the extravagant procedures for the very elderly, and we shouldn't plan on bailing out healthy young patients that can undergo surgery with very complex, high-risk catheter-based procedures. Personalized decision-making leads to better outcomes. Thank you very much for listening. I hope this has been helpful to help you understand how we make these decisions, which are very, very important for each of our individual patients.